Hey everybody, it's Izzy Firth with LifeSpan. Today is primary election day in Maryland, June 23rd, and today's topic for our program is really about health information technology. And you know, by way of background, I was doing a little surfing on the internet about where we are as a state with information technology. And on DHMH's website, there's a statement about how Maryland is considered a leader in putting together health information exchanges. Who knew? You know, operating in Maryland here, it's kind of hard to understand what's happening in the rest of the country and other states, but apparently we're out in, near the front on this kind of activity. So to talk a little bit more about health information exchanges, I've invited David Horrocks here today. David is the executive director of CRISP, which is Maryland's Health Information Exchange. So welcome, David.
Thank you, Izzy.
Tell us a little bit about CRISP and what it is.
Well, CRISP does operate a health information exchange for the state of Maryland and also regionally in the District of Columbia. Mm-hmm. And the purpose of an HIE is first and foremost to get clinical information into the hands of the doctors or nurses who are making medical decisions and treatment decisions on behalf of patients. So it's getting the right information on the right patient into the right hands at the right time.
Great stuff. So who's signed up to the Health Information Exchange in terms of the entire healthcare field in Maryland? Who's using this exchange now?
Yeah. Well, CRISP is a nonprofit organization, a membership corporation, and we really were started by 4 organizations, by the 3 large hospital systems in the state, University of Maryland Medical System, Johns Hopkins, mm-hmm. and MedStar, but also by Erickson Retirement Communities, which of course has a background in long-term care. And at the very beginning, those organizations wanted to focus on seniors showing up at the hospital and having the right information. So it was one of our aims from the very beginning.
Wow.
That group who started CRISP then expanded participation, and so we have participation by many of the clinicians, hospitals, and practice representatives throughout the state of Maryland and some from DC as well. Participation in CRISP has been particularly strong with the hospitals in the state of Maryland. We have 46 hospitals in Maryland and 46 acute care hospitals, and all 46 are connected to the HIE and participate with us.
So virtually every hospital in the state of Maryland is participating in the CRISP network.
That's right.
And how does this help them? So I'd like you to talk about that, but I also, more importantly, want to get to the point is how can CRISP help LifeSpan members do their jobs better?
Sure.
Why should we participate in this?
Yeah. Well, I'll start with with the services that we provide today to hospitals and to ambulatory practices. Mm-hmm. And there's really 3 core things that CRISP does as an HIE. The first is that we collect summary medical records, mostly from hospitalizations, but also from radiology reports and some lab results and then some medication histories. We collect those and then make them available at the point of care. The sort of classic use case would be in the emergency room. A person shows up at the emergency room, and the clinicians at the emergency room can check prior records, understand the prior diagnoses that the patient has had. They can see discharge summaries that may have happened across town last month, and lab results and radiology reports. Okay. And today, that system is queried through we call it a query portal.
What does that mean?
It's where you go and you check.
Okay.
Here's my patient. Are there records available for my patient?
So I'm a DON, and Mrs. Smith has just come back to our facility from the hospital.
Mm-hmm. Yeah, as a DON, you could go into the system and you could find records from that hospitalization, and you might find lab results and radiology reports, and importantly, you'd find discharge summary.
What if, one of the biggest issues our members face in dealing with transfers between the hospital and our facilities has to do with medication reconciliation.
Okay. Yeah.
Does CRISP help on that at all?
We collect medication information from two different sources.
Mm-hmm.
The first source is from SureScripts. This is SureScripts is a network of pharmacy benefit managers and retail pharmacies, which collect records either through billing information or dispensing information. And the primary purpose that these records are collected for is to support a doctor who's e-prescribing.
Mm-hmm.
So before you would e-prescribe, you can see existing medications. Well, that same information is potentially useful, again, in the case that you described, Izzy, and you can get to that information through CRISP. That information is usually considered to be about 80% complete.
Okay.
Not every pharmacy participates in SureScripts, and not every medicine that the patient has is your insurance doesn't necessarily pay for it, so then it doesn't go through one of those claims systems. So generally it's considered helpful but not complete. A second source of information that we have for med reconciliation is the State of Maryland's Prescription Drug Monitoring Program, or PDMP. This is only applies to Schedule 2 through 5 medications, and it really was put in place with a special concern for opioids and medications that are addictive.
Sure.
Because clinicians need to understand and sort of get out in front of patients who may be forming an addiction to a medication.
Right.
That's sadly a problem that results in many deaths in the state of Maryland and across the country. So the PDMP is there first to help clinicians combat prescription drug abuse.
Right.
But it's also helpful for med reconciliation, at least to a degree.
So the information that's on the exchange, is that real-time information? Another important issue that I think is confronting our staff is having timely, accurate information about our residents when they're coming back, or when we're sending them to the ERs, making sure that the data and the information about their status is as real and close to the time that they're transferring as possible.
Well, it's our aim to make the information as real time as possible. In some instances we succeed better than in others. We generally say it's near real time. A lab report, for instance, or a radiology report will be posted as soon as the lab information system makes it available within the hospital. And so we'll have that near real time. The fact of someone's visit to the emergency room comes to us through a message called an ADT, which is an admission discharge transfer message. We receive that within a matter of seconds or maybe a few minutes of when an admission actually occurs. But a discharge summary, for instance, we only really have a final discharge summary once the physician on the other side signs off on the discharge summary, and that may be some time or days even after the discharge. As soon as it's signed, we get it pretty quickly, but not until it's signed. Medications tend to be a day or two delayed. So they are also not real time.
Okay. You know, David, LifeSpan represents a broad range of kinds of organizations, not just skilled nursing facilities. Is CRISP a service or an exchange that other kinds of providers ought to be tied into? For instance, like assisted living organizations or continuing care retirement communities, or other levels of care. Do you see a utility for those organizations too?
Yeah, I think that the most value in an HIE happens when organizations are working to coordinate with other organizations. So to the extent that most of the care you're providing is coordination within a facility, then the HIE is maybe not that helpful. Or maybe most of your coordination is with a particular hospital where you already have some custom connectivity and you can access records. Then the HIE probably wouldn't replace that. But if you need to coordinate with multiple facilities, or there are multiple practices who all need access to records and to be coordinating, that's when the HIE would be most valuable.
Okay. One of the things I learned recently from the health department is that according to recent survey of skilled nursing facilities, 72% of skilled nursing facilities say they have some type of EHR system in place, which is a stunning number.
Yeah, surprised me.
Given previous survey numbers have been a lot lower than that, and if we are to believe that number is accurate, that's a big move. And do you see that kind of move toward participation in CRISP, for the post-acute care providers, and do you anticipate more organizations participating from post-acute in CRISP?
Well, it'll be more anticipate. We don't see a big movement thus far.
Yeah.
We do have a handful of skilled nursing facilities who do share records with us, and generally the reason that they're doing that is they want to coordinate with their hospital partners.
Right.
They may have a hospital partner who wants to understand when a patient who's been transferred to skilled nursing is discharged, and they're trying to keep track of that, because together with their hospital partner, they are trying to manage readmissions.
Right.
And so I would say that payment reform is driving some of this need to coordinate. And when there's a need to coordinate, that's when the HIE can be a helpful tool.
Do you think that hospitals may see CRISP as such a valuable tool that they'll be asking their partners, like post-acute care organizations, to be participating in CRISP in the future?
That certainly could happen. In fact, I'd say it wouldn't surprise me at all. But I think they'll ask them to participate towards a particular end. It will be as part of a program to, say, manage readmissions, or maybe there will be a program to manage a little bit higher level of acuity within the long-term care facility, and as part of those programs, they'll say, let's participate in CRISP in order to do this thing, so we can calculate our admission rates or patterns. So I think it'll be connectivity, but towards a purpose.
Okay. Well, what do you all have planned in the works for CRISP? What are your next steps? What are you working on now?
Yeah.
And how can that be something that would be relevant to what our folks do?
Well, I mentioned the query portal, which includes the prescription drug monitoring as the first service. There's a second service that is important, especially I think to the ambulatory practices, and we call that encounter notification service. And the way this works is we take a patient list from a primary care provider or from a group of care coordinators, and we sort of sit listening on the system to see if any of those patients are hospitalized, either show up at the emergency room or have an admission or a discharge, and then we send a notification, and it
to who?
To the primary care provider.
Oh, okay.
And often now that primary care provider will have, let's say, a nurse care coordinator who receives those notifications, and then he or she can coordinate the physician making a follow-up phone call, getting a visit scheduled, the things that would be helpful for care. And that service has been operating for about 2 years, and we have maybe 300 practices who use it. We are making additions to the E&S capabilities. So not just would we send a notification, but we can also push relevant documents, especially a discharge summary. So your primary care provider would know that you've just been discharged, but we'd also push out that discharge summary.
Okay.
And another change is we're trying to do this as what's called structured data, and to use some standard formats, sort of national standards. A CCDA document format is one of the standards we're trying to adopt. And the idea here is that you wouldn't just have a document you could print out and read, but you could kind of ingest it into the far end EHR as structured data. Okay,
so I think I'm following you. I, like many of the people who are practicing senior care, I consider myself a neophyte in a lot of what's happening in technology, but I do know that the systems that our members are purchasing, one of the key concerns is that those systems have the ability to connect and talk to their key partners, whether it's the doctors or whether it's their hospital partner, whether it's their pharmacy. But the ability of these systems to talk and connect to each other is just, fundamental to what they're doing. And everybody who is selling you a product is going to say yes, they can do that. But we're finding that not as well as we'd like them to.
Yeah, and sometimes those vendors will they'll say, yeah, we can do it, but it's going to cost you $30,000 to have this interface. Often it's an HL7 interface.
So great segue to money.
Yeah.
These systems are hugely expensive. We're very price sensitive in our field on these things. Do you anticipate any funding availability in the coming years from the state, from CRISP, to help create incentives for more adoption and more participation in systems like CRISP?
Well, I certainly hope that there is. Now, I have no foreknowledge of what grants will be made available. CRISP is an organization. We receive our funding through hospital user fees and also from some state grants. We have not charged long-term care facilities any membership fees or connectivity.
Well, that's good to know. So participating in CRISP is free to the extent that you can sign on and tap the data. It doesn't cost anything.
That's right.
It's good.
There have at times been small grants to try to encourage connectivity. The Maryland Healthcare Commission had a challenge grant over the last several years, and a few facilities were able to use that grant.
Yeah, a number of LifeSpan members did participate in that. Yeah.
Whether that can be done more broadly, I sure hope so. I think it's needed.
Very good. Well, thank you very much for joining us today, David. And maybe we can have you back sometime in the future. We can talk about all the progress that we've made.
We'd be happy to do that. Thanks, Izzy.
And thanks for joining us. Stay tuned. We'll be probably broadcasting another program next month. Thanks. Bye-bye.